What's up, guys? Welcome to another video. Welcome to another vlog. This is not really a vlog at this point. This is more so a topic video discussing kind of a specific topic. This video, like I was talking about in my last vlog, there's kind of not too much variety going on in my life, so I feel like vlogs are boring. I'll probably start putting up some more vlogs in a couple of weeks. I think stuff will get a little bit more exciting as far as kind of things to do, so it'll be that. But as far as this video, it's pretty much just going to be a topic video about the differences between inpatient and outpatient PM&R, and really what some people have commented and been asking for are some of the practical differences you see once you start really getting to practice that are different from the med school or from the residency level. And if you are a med student, resident, anyone, I absolutely love giving back and helping because I've received so much help myself just from free advice and asking people things. So if you got anything, drop them down below in the comments. Find me on Instagram at themskdoc. Send me a DM. I'm more than happy to respond. I actually just responded to an email. A med student was asking me some questions about PM&R. He reached out to me via DM, so I emailed him back, kind of a response that big. So if you got anything, feel free to send it. I'm happy to help. Alright, so this video is the 3 differences between inpatient, outpatient, PM&R, and these are kind of the 3 biggest differences that I think, and that is number 1, setting and kind of location. Number 2 is going to be the patient responsibilities that you have as a physician, and number 3 is going to be the pathology or the types of patients that you see. Now, you might be thinking the setting's pretty obvious, but it does play a pretty big role in the lifestyle and kind of general flow of how you do things. Number 1, when you're in inpatient kind of care and you're taking care of that and you're the physician, the patients are already there. They're admitted to the hospital. So you necessarily being there a certain amount of time doesn't matter because you're not waiting, or patients aren't waiting to come see you. They're not kind of coming on a rolling basis. They're already there. So essentially, you kind of have a little bit more flexible of a schedule. Obviously, stuff has to get done in a timely manner, but it's more or less to some extent on your schedule, and you can kind of just walk into the room and kind of take care of things. The other thing is you don't have to squeeze everything into a 30-minute appointment. If you see a patient in the morning and you think something might be going on, you can go and see them later in the afternoon or in the evening or whenever it is that you want. The patient is there, you're their physician, and kind of however much or little contact you want with them is up to you. It kind of just depends on your discretion of what that patient needs and how you can best help them. On the outpatient side, completely different story. You're seeing patients on a timely manner and they have set appointments for that. So you are busy managing a clinic schedule essentially. So patients are coming every 20 minutes. Sometimes they're late, sometimes they're really early. You have to manage that, be able to see them, get everything that they need done within that set amount of time, get the orders done in a timely manner, and make sure that pretty much their care is coordinated with how much time you get. Now, the notes might not be done that day or the night even, so notes can linger, but you have to make sure that the care does get coordinated as the patient is essentially leaving so that things can get underway. So for example, if a patient comes in and they need a stat MRI, you have to get that coordinated, make sure it gets done, and then read it on time. There's not really too many other backstops or people watching you. This is your clinic. Next up comes patient responsibilities, and this is what you are responsible for the patient, and these are very different for the inpatient and outpatient side. So for the inpatient side, there is a lot of paperwork relating to the patient hospitalization. There's a lot of medical records, a lot of complex documentation. You're kind of responsible for a lot of that and making sure that hospital stay goes smoothly. There's a fair amount of work kind of associated in the back end where that goes, but at the end of the day, you're only really responsible for that patient when they're there in the acute time period, when you are their attending physician while they're hospitalized. That's really the main kind of time period where you're there with them. Sure, if you have an outpatient clinic, you sometimes see them as an outpatient too. That's completely different. That's the outpatient side. But strictly on the inpatient setting, you're responsible for their acute hospital stay. So that's getting authorization for them to come to your hospital, kind of working on the history and physical all the way up until discharge and coordinating care and making sure they have a seamless discharge. That's what you're responsible for. When it comes to the outpatient side, that is completely different. You now have an ongoing relationship with this patient for however long, essentially until you move, leave the practice, the patient moves, however long it may be. You can see a practice, or you can see a patient at the same practice for decades and just really develop that long-term relationship. The other thing that comes along with it is that any time that this patient is under your care, which is essentially however long that relationship lasts, they can send you a message. And there's different levels of kind of layers to accessing you. There's some practices which are very kind of, we're going to give you physician access, so they can get directly into your inbox on whatever your EMR is, and some have answering lines, nursing services, whatever, that are going to triage questions and help kind of get some of those lower level things that you should be worrying about as a physician. So you're kind of available at all times. You can decide to respond whenever you want, but you will have kind of things rolling on a daily basis. If you order imaging, testing, any of that kind of stuff, or if someone's sending you stuff, that can come at any single point. So for example, if you go on vacation for a week, you might still have a ton of stuff blowing up on your inbox because people are still messaging you. You're still responsible for their care. Whereas if you are now, let's say, not an acute hospital, someone's covering you, so all of this stuff for the acute hospital stay for those patients goes to the covering physician. And then comes last but not the least important is patient pathology, and this is very different between outpatient and inpatient. And the inpatient pathology can essentially be anything. When patients are coming to an acute hospitalization or an acute rehab stay, essentially they've had something acute happen to them, and now they're coming to rehab because they have deficits and they're below their functional baseline, whatever that may be. So whether it is they had a stroke, whether they had a heart attack, whether they had an amputation, whether they had GI surgery and they had major kind of big open abdominal surgery, whether they have a fractured hip, whatever it is, whatever has caused them to decrease their functional level, they might be coming to you for rehab. So you kind of have to know a little bit of everything and be able to kind of care and cover that coordination kind of throughout. Now, the one thing with this is you don't necessarily have to be an expert in all of that because a lot of inpatient hospitals do have support from other consultants. So you have an internal medicine physician who's handling really the nitty-gritty of a lot of those things, such as maybe a complex heart failure patient. Or if it is so complex, you can also potentially consult a cardiologist for this. So there's a variety of support you can have as an inpatient physician, but for the most part, you're going to be their primary physician during that stay, and you're going to be managing and taking care of a lot of those basic medical things, so you definitely need a strong medical knowledge. When it comes to the outpatient side, you can be as niche down as you want, or you can be as broad as you want. This is kind of dependent on your practice and what you want to do. If you want to strictly just do musculoskeletal medicine and practice only doing no procedures, just seeing people, you can do that. If you want to do just procedures, you can do that, although kind of difficult to set up. But you can do kind of whatever you want. If you want to be a jack of all trades, see all kinds of patients, you can open up in your clinic and kind of do that as well and see all kinds of outpatient things, from things like outpatient strokes, outpatient traumatic brain injury, outpatient amputations, whatever it may be. But for the vast majority of people and vast majority of clinics and people who are hiring, they want some specific kind of field or niche that you're going to be offering for that position. So that's usually what people end up doing. So for example, for myself, I am niched down into non-operative sports and spine care. So that essentially means large axial joints kind of in the spine, as well as peripheral joints, and not really dealing too much with the fine nitty-gritty kind of musculoskeletal things that someone like a pain physician might do if they're doing a specific nerve block or a visceral pain block. And I'm also not going to be doing just electrodiagnostic studies like someone who does a neuromuscular fellowship. I'm a little bit broad still, but I've niched down definitely into musculoskeletal medicine, specifically non-operative musculoskeletal medicine. But I'm still doing a fair amount of injections with fluoroscopy and all those different kinds of things, which have expanded my skill set. But on the contrary, if a patient comes into my clinic and they are a post-stroke and they have a foot drop because of that, that's probably something I'm not going to be dealing with on a longitudinal basis. Sure, I'll still see them and set things up because I do have a knowledge of that based on my training as a PM&R physician, but I'm not going to be the one helping them manage their spasticity or anything else long-term. I'm going to find someone who does and make sure they get set up with them. And that is really it for this video. Relatively short, sweet, and simple. I just wanted to talk about the differences between inpatient and outpatient PM&R and the different kind of settings for those of you who are kind of choosing what you want to do, whether you're in med school or early on in residency. By the time you get later on in residency, you kind of realize what this looks like. But if you have any other questions, comments, or anything you want to see, drop them down below in the comments. Like I said, very happy to help out with anything and give back to the community. So I'll see you in the next video. Make sure you subscribe. Don't miss things. Life is about to get a little bit more interesting, so stay tuned for some vlogs, and I'll see you in the next one.